Thank you everyone for joining us this evening. Today we're going to talk a little bit about concussions. There we go. So just a few learning objectives before we get started. Just some things to keep in mind as we progress forward through the presentation. The first is to understand what concussion is and how one may occur, to recognize the signs and symptoms, and to know when it's time to receive care. To understand the roles of various healthcare providers in the evaluation and treatment of concussions, and to gain familiarity with the assessment tools and treatment methods to better engage in the conversation. One of the things that I find incredibly useful is when people have a little bit of a background in some of the knowledge already, so that way it's less of an I say you do, and it's more of an equal conversation between the healthcare provider and the patient. So this presentation is divided into 4 parts, the first of which will be general background info surrounding what a concussion is and how one might occur. So some statistics here. We have a 1.6 to 3.8 million reported concussions per year, and that number continues to grow as diagnostic tools continue to improve. Around 28.9% of adults report sustaining a concussion sometime in their lives. So it really speaks to how often these injuries could actually occur, whether it's at a young age or older. 8 to 10% of all contact sports athletes suffer from concussions yearly, and around 80 to 85% of concussions are symptom-free within the first 7 to 10 days, looking to fully resolve within the first 21 days with the proper care. The most common age ranges where a concussion can occur is around that 9 to 29-year-old range, the first 2 to 3 decades of life. It's when a lot of folks are participating in sports, kids and young adults, as well as, occasionally engage in some behavior that's, a little bit more erratic. Normally, females are actually at a greater risk than males when, performing comparable activities. So just one thing to consider, that if males and females are engaging in either similar sports or similar day-to-day tasks, that they may be at a greater risk to sustain a concussion. So what is a concussion actually? A subset of mild traumatic brain injury, and this fancy definition here I pulled off of the internet, a traumatically induced transient disturbance in brain function. But much more simply, it's an injury to the brain that results in a temporary loss of normal function. This often happens because of the mechanism of what actually goes on in the skull. So I like to use the glass of ice water analogy when explaining this to my patients. If you imagine a glass of ice water, and obviously without making a mess, you're gonna put some ice in a glass of water and you move it around slowly, you can see that the ice moves independently from the glass as you move it. Similarly, the brain floats kind of free floating within the skull, which kind of predisposes it to some injuries, either shifting forward or backward when either suffering a direct blow or when the body moves rather quick. So as I just said, some common causes here are some direct trauma or impact to the head, as well as rapid acceleration or deceleration of the head or body. So such as, like, let's say a hit in football, it doesn't necessarily have to take a blow to the head itself to sustain a concussion. The fast whipping motion of the body will pull the brain in such a way that it will actually knock against the interior of the skull and cause some damage there, which could result in a concussion. Okay, some more specific common causes here to kind of highlight, some more of those generalized definitions prior. We have sports injuries, both contact versus non-contact, impact trauma, either against a fixed object or if something's coming at you or moving. Falls, which happen more in the geriatric population, but could occur in anybody, motor vehicle collisions, etc. The list goes on, but it all comes back to those, kind of 2 key causes that I mentioned earlier. Reported symptoms are very important because this is what the person who sustained a potential concussion is telling you. Something such as, a headache or pressure within the head. If they sustained a loss of consciousness that maybe wasn't particularly visible or observable. If they either feel nauseous or if they feel like they're going to vomit, they're experiencing dizziness, double vision, blurred vision, sensitivity to either light or noise, or just kind of feeling not quite right, that sluggish, hazy, groggy feeling, as well as some mood changes. These are things that are often experienced by the patient, and so it's very difficult to get an exact understanding of what they're going through. So it's important to lock into some of these key factors if they happen to report it, or could potentially give you some good questions to ask if you want to make sure that they're okay. Some observable signs from outside. So some things that they may be unaware that they're doing that an exterior person could observe. such as changes in mood, behavior, or personality, difficulty concentrating or answering questions, appearing, dazed, confused, maybe perhaps issues recalling some of the previous events of what happened prior, or just general balance and coordination problems. So I bring up these, different observable signs, these symptoms, because it ultimately relates to areas of the brain that could be impacted. As you can see, there's different areas of the brain that serve different functions. And generally speaking, if you see a particular pattern, it could be related back to this diagram here. This is not really something for the general population to know, of course, but something that alludes to what a healthcare provider is thinking when someone first walks through the door. I've included in here some pictures of relevant anatomy. This is not for memorization purposes. This is more to show the complexity of the head and neck and to, sort of appreciate the understanding that it takes to evaluate a concussion and the surrounding structures, between the brain itself, the various arteries, nerves, and the surrounding muscular structures that go into supporting the head and neck and its various functions. One topic to consider here, just considering again that glass of ice water analogy, is a coup versus contra coup injury. So a coup injury is defined as an injury to the brain at the location of the initial injury or impact, and that's more associated with a moving object impacting the stationary head. Okay, this is when you would expect the injury to occur in the same location, as the area that impacted. A contra coup injury is caused by that reverberation of that ice water, so to speak. It's an injury to the opposite side of the brain as the initial point of impact, and can ultimately, lead to further insult and function. Some secondary conditions to consider following concussions, because sometimes it doesn't always just end with the concussion itself. We concern ourselves with second impact syndrome, where a person may not be fully recovered and can often suffer heightened symptoms, prolonged recovery times as a result of not taking advantage of that full recovery. We have post-concussion syndrome, which is a cluster of symptoms that can last longer than expected. This has several categories, which we're going to highlight later, but really alludes to how in-depth the assessment and treatment of concussions can be based on these prolonged symptoms. And the last here is whiplash-associated disorder. It's a cluster of symptoms related to the cervical spine that can often happen in conjunction with a concussion, because more often than not, the neck is implicated in the impact to the head or the rest of the body. Okay. Part 2 of our presentation here is recognition and referral. So understanding how to go about recognizing a concussion and then making sure that patient is able to reach the proper referral source. These are some words to live by. I say this to all of my patients. If you feel or see something, say something, and when in doubt, rule it out. Okay. With concussions, they can seem pretty minor, most of them going away on their own in that 7 to 10 day period and fully resolving by 21 days. But in some cases, they can really be more extreme and can lead to many other deficits down the line. Early recognition is key in, solving the problems related to a concussion. And, it's important not to, it's really important not to take that lightly and to see a healthcare provider the moment you suspect any kind of trouble. So these are all of our slides from before: the causes, symptoms the patient feels, and the visible observations from others. When you put all these together, it really dictates, a proper picture of what a clinician is looking for when a concussion first happens. When we relate all of these things, it really helps us to pick and choose how many different combinations of concussions can happen and all of the different, methods that we go about assessing these injuries. Some other things that we consider that weren't previously mentioned were risk factors. Most notably, a previous concussion being a prominent risk factor in how one might, recover or sustain a subsequent concussion. History of migraines, a diagnosis of ADHD, and as well as, sex being, females greater than males, or age, that 9 to 29, age range. Motion sensitivity or pre-existing, symptoms related to vision are all things that can either worsen a concussion or make concussions more prominent or common for a particular population. Okay. By knowing the mechanisms of the injury, predisposing risk factors, as well as the signs and symptoms, you maximize the likelihood of detecting a concussion. Found this to be important enough to put word for word on the slide because even someone who's not a licensed healthcare provider can take an active role in determining if themselves or a family member should be seen by somebody. And an important tidbit to remember here is that concussions are like snowflakes. No two are alike. There are so many different presentations related to these observable signs and symptoms experienced by patients. So it's important to reduce bias, eliminate assumptions, and act on that first sign. Some relevant examples here, which I've included just for your own knowledge as to how different these concussions can be. You're watching your son's first freshman football game when a player on his team comes off the field after a big hit. You see that he's visibly confused and takes several missteps and can be heard asking what happened during the last play. Another scenario I've outlined here is you witness a single car accident and run over to help as a good Samaritan. The driver steps out of the vehicle without visible signs of trauma at all, though you notice the airbags deployed. He reports feeling fine but has a headache. Both scenarios here are incredibly different, and both ways that the patients present are incredibly different. But with my knowledge here as a healthcare provider, I would be thinking concussion with either scenario and looking to take them on the route towards assessing their symptoms and understanding the severity of the impacts. After a suspected concussion occurs, a first responder would hopefully be on the scene to evaluate the injury and assist in determining next steps, whether that's through calling 911 for EMTs or if it's during a sporting event, being seen by a certified athletic trainer. In most scenarios, the general population typically is either driven to the emergency room or primary care physician by a family member, or 911 is called. Some folks just kind of wait it out. I typically don't advise that, but it's something that does happen. Later on in the presentation, in my key takeaways, we'll go over what to do in those scenarios. But really, more often than not, the general population will be seeing their primary care physician. Some other possible routes of referral, which you may not be aware of, and which will be featured prominently in the rest of the presentation, are neurologists, neuro-ophthalmologists, which primarily focus on neurocognitive function related to the eyesight or eye movement, neuropsychologists, who primarily focus on mental health associated with neurological conditions, as well as anxiety, mood, or behavioral disorders, physical therapists, which I am myself, and certified athletic trainer. Most people don't actually know that physical therapists do have a prominent hand in the long-term recovery for concussions, but they don't always have to be the only route. That's just why we list these different professionals here to show how it's a multidisciplinary approach, how so many different hands can come together to treat the patient. I always encourage my patients, like I said, to become an advocate. So when you consider the appropriate referral for a suspected concussion, it's important to know your state's laws and practice acts to ensure proper pathways are taken. These practice acts can be Googled online. They're listed on state websites and really dictate how each state individually manages concussion care, because it is such a large problem and does have many implications. If you yourself are concerned about how a particular family member is being treated, or if perhaps you want to educate yourself on the process and a little bit more of how it works, I would encourage you guys to go, onto your websites, your local state, guidelines, and try to see what you can find. Part 3 of the presentation here is the assessment. So what we actually do, both at the time of the injury as well as, in the clinician's office later on after the primary assessment. The standard evaluation has 2 basic parts, patients are aware. It's the subjective questioning, where we talk to you a little bit about what you're going through and understand more of your problems, as well as the objective testing, where we gather a lot of the data associated with your actual condition, relate it back to age-matched norms, and determine just the extent of the injury of what you're going through. So we can then, chart a path of treatment and refer as needed. The primary assessment is an assessment that occurs at the site of the injury or immediately following the injury. This is something that could occur, on the athletic field, at the time of a motor vehicle collision, in the emergency room, and it involves tests and measures to rule out significant trauma or impending life-threatening conditions. Whenever dealing with something with the brain, the cervical spine, these are all very sensitive areas that have a lot of implications for, day-to-day function. It's important that we rule a lot of these things out to ensure that, a secondary assessment can be conducted by another healthcare provider without worrying about either worsening symptoms or perhaps another condition developing under the surface. Again, this, first primary assessment is administered by first responders such as EMTs, athletic trainers. There's other healthcare providers as well. These are 2 of the most prominent that people interact with on, a daily basis with concussions. These are some of the extensive things that are done during a primary assessment, all the way from EMS activation and initial observation of symptoms, all the way down to delayed recall tests, exertional tests. There's many different facets of these evaluations. I highlight this because there are many different things that they need to do in a very short amount of time. And it's important to focus on the key details, especially when these healthcare providers are speaking with you about your condition and what you're going through. There are so many different things that could be going on. It's important to remain an advocate for yourself, to educate yourself on what they're saying, and to understand a little bit about what they're doing. What is actually causing symptoms and related versus something that they just may be screening just to rule it out. Some more important aspects of the primary assessment I've highlighted here, the pupils being equal and reactive to light. So when the pupil is exposed to a particular absence or bright burst of light, it'll contract or dilate accordingly. And this is something that in patients impacted by concussions will either lack or may not experience as well as the average person would. Slurred speech, numbness and tingling of limbs, or loss of limb function often indicate a problem that is more severe and warrants immediate referral to another healthcare provider. Clear, transparent fluid from the nose or ear, insults to the areas of the brain where cerebrospinal fluid is flowing, often regulating pressures within the brain, different nutrient content. These are things that need to be referred. Seizure or loss of consciousness, or signs of cervical spine or skull fracture, again, very severe conditions that you would want to make sure are checked up on. One thing that is done on site, at least in most instances where an athletic trainer is involved, is called the SCAT-5 questionnaire. The reason I put this on here is that while most people may or may not interact with an athletic trainer, this SCAT-5 questionnaire is pretty comprehensive and encompasses a lot of the things from that previous primary assessment slide. So by using one tool, we can cross off a lot of the different categories that are involved in a primary assessment. And so it makes it a very functional and reliably invalid tool to use when evaluating concussions. The other great thing about this tool is that a baseline can be taken, which means that at the beginning of a season, or let's say if you're just curious, these scores can be collected and saved for later on, and then compared if a concussion were ever to occur. And that way if there's a change from one instance versus another. One key set of tests or assessments that was mentioned very previously on that slide, very briefly, but not included in the SCAT that I wanted to highlight here, is a vestibular ocular motor screen assessment, or the VOMS assessment. It's a series of 5 tests that have a 94% accuracy in detecting concussions. And that's primarily when there's an increase in 2-point symptoms on their rating scale, or a near point convergence of what's called 5 centimeters or more. It's not exactly important for you to know. It's one of the things that I myself as a healthcare provider are looking for. But by looking at these 5 tests, it's a very quick and easy screen to determine if a concussion is present and if further evaluation should be conducted. Overall, a thorough primary assessment helps to decrease the likelihood of second impact syndrome, post-concussion syndrome, or overall worsening of the initial injury by increasing the likelihood of positive decision-making. So by ruling out a lot of those, very severe conditions that could lead to further problems, and by ruling in a lot of the things related to concussion, we can get the proper care faster. We can make sure that patients, reach the appropriate steps to recover quickly and ensure that this is no longer a problem so they can continue going on with the activities they want to do. I've been mentioning a lot about a primary assessment. There is a secondary assessment that then occurs after the initial injury. Okay, this is where I become more involved as a doctor of physical therapy. This is when the injury has already occurred. You're going into either an outpatient office or a specialist office to gather more information and to compare from the time of the initial injury to the current symptoms that you're being presented with. This is where a full medical history is gathered, and any kind of referral that needs to be made at this point is something that's developing from that initial onset that hasn't yet been addressed. Aside from that, we're going to assess a series of symptoms, place a concussion in a particular category, and begin our treatment. So again, the primary goal is what symptoms continue to affect the patient and how can we go about intervening in this process. Subgroups of concussion symptoms are listed here: physiologic, ocular, vestibular, anxiety, depression, or mood, cervical, post-traumatic migraine, or cognitive. Okay. These subgroups here help to sort of provide guidance to the clinician, as well as to orient the patient and clinician together on what goals can be achieved over the course of the treatment time together. It also helps to streamline the evaluation to ensure that we go down the proper, the appropriate pathway of treatment. Apologies. There we go. And part 4, of course, treatment. Hopefully no one is treating concussions like this. So the initial management of concussions, where a lot of people tend to, sort of really ask the most questions from me. A lot of folks want to know really how to treat their children if something happened on the field, or if there was a pretty traumatic event and they want to make sure that they're doing things the right way. This is a great slide to take away from. Rest in the first 24 to 48 hours. Take time away from school, take time away from work, focus on the cognitive recovery, focus on the what's called physiological recovery. So the body's ability to restore normal biochemical reactions and begin to heal. Okay. You want to reduce stimulus. So definitely no driving, no tech such as phones, laptops, TV, no, loud noises, bright lights, anything that can, really spike brain activity. We want the brain to be mellowed out. We want it to be able to rest in that full, relaxed cognitive state. So nothing that can modify that cognitive state, such as drugs, alcohol, and NSAIDs here, as we want the body to go through its natural inflammatory process. Overall, through the initial management, it's important that, whoever that caregiver is, to monitor closely and watch for signs of the declining status, such as some of the observable signs or reported symptoms from earlier in the presentation. Again, I want to bring up the subgroups of concussion symptoms because we're going to go into a little bit more of the specific assessment and treatment of each one of these. When initially creating the presentation, I was debating whether or not to group all the assessments and then all of the treatments into their own separate categories. It seemed much more logical to take each one of the subgroups and to describe specific assessments that can be done, followed by their direct specific treatments that coincide with them. This is something that is not meant to be making anyone an expert at concussion management and treatment. It is meant to primarily serve as an exposure to the information, so that way you can engage in better dialogue with your healthcare provider, and better participate in the conversation to perhaps better recognize what someone's doing as they go about the evaluation and treatment. So for assessment of the physiologic symptom group, the primary test that we're going to be using is the Buffalo Concussion Treadmill Test. It is a test that's done to observe exacerbations in symptoms during strenuous physical or cognitive activity. The patient's baseline vitals are taken, as well as symptom presentation, different reports of exhaustion and heart rate, blood pressure. And we place the patient on a treadmill with varying degrees of incline. As the test is progressed, these symptoms, these vitals, are then taken progressively, and we're gauging from the time they started to the time they end how they change. Overall, the test has a few key determining factors as to how it's stopped, and those stopping signs indicate the level of recovery that a patient is currently undergoing, or if they're perhaps ready for additional activity or additional exertional training as a result of a progressed outcome. Overall, this test is reliable and valid, and is something that I use prominently in each concussion management if it's indicated to be used. Overall, the treatment for physiologic concussion symptoms is submaximal training as tolerated and is permitted by existing return to activity guidelines. What that means is that along with those practice acts that exist online, there are also state mandated return to participation protocols, whether that's for work or for play in sport. These protocols dictate the rate of recovery, as well as what a patient might be going through to better provide guidance throughout the rehab process. It's important that anyone who may have a child participating in sports or decides to return to play following a concussion follow these return to play guidelines to ensure that the patient is safely returned and is at minimal risk of undergoing either second impact syndrome, post-concussion syndrome, etc. For the ocular symptom group, there are a few tests that we have here, such as the vestibular visual analog scale is a conducted questionnaire to gauge symptoms and has been shown to be very accurate in reporting ocular symptoms to indicate potential concussion. The VOMS assessment, which we previously discussed, as well as the Maddox rod and cover-uncover tests, which are two tests that gauge, the potential eye movement and deflected visual fields when assessing vision, and if whether or not it falls within the baseline of what's considered normal, or if there is abnormal movement that would indicate a potential visual problem related to a concussion. With any kind of assessment related to the ocular system, it's important to refer to a neuro-ophthalmologist to, get their take on the injury, as well as to involve them in their plan of care, so that way you guys can develop a cohesive treatment protocol between the healthcare provider and the patients. Treatment for ocular symptoms are as follows. Brock string exercises and pencil push-ups are two ways to work on convergence and focusing. A Brock string is when you have a string with beads at various intervals held away from participant's face. And what they do is they try to focus on each individual bead. As the distance moves further away, the difficulty can either increase or decrease. And it's a way to work on those different levels of focusing. Pencil push-up is when you hold your finger or an actual pencil in front of your face and slowly move it closer and further away. Again, to work on focusing on your gaze and to, gradually reduce symptoms as you focus on an image. Saccades is a concept in which you focus your eyes on two different points, one after the other in quick succession. So for instance, two separate objects, one on the left and one on the right, and quickly shifting your gaze between each one is a good way to start slow and progress and move quicker when training ocular coordination and improving your vision. Near point convergence, again, more along the lines of pencil push-ups, but overall, the goal is to reduce those symptoms and gradually restore function over time to reassess and to progress. For the vestibular symptom group, balance assessments are very relevant here. The vestibular system is composed of three different categories. It's vision, sensation, and then the actual vestibular component of balance, okay? And balance is something that is often more physical, it's more observed, and isn't something that's always detected by the patient. We do this by doing something called a best test, where you place your feet in a number of different positions and then change the surface that you stand on. We also have something called the Dix-Hallpike maneuver, which I wanted to specifically highlight here, because it is a maneuver to test for benign paroxysmal positional vertigo, or BPPV. This is when a patient actually reports that the room is spinning and symptoms are often quick, either 30 seconds or less before they resolve. It's something that can occur hand in hand with concussions, but requires a separate form of treatment that a physical therapist can also provide. For anything related to the vestibular system, the physical therapist is going to refer to a neurologist for that more well-rounded care. Some different treatments. These, again, are things that you're not expected to know, but I wanted to list here for familiarity: adaptation, gaze stabilization, habituation. Each one of the things listed here are strategies that a physical therapist can use to engage in treatment of the vestibular symptoms that a patient's experiencing. One thing I think is very important to note at the bottom is canalith repositioning maneuver. That is the actual act of fixing that BPPV by moving through a series of positions very quickly. This is something that I do with a lot of my vestibular patients here in the clinic as a physical therapist. It is something that can provide quick relief when vestibular symptoms are caused by BPPV. It's important to note that vestibular symptoms can go down a rabbit hole of many different conditions. And so when something like that is suspected and maybe doesn't fit the right criteria, that we refer to the appropriate healthcare provider, such as a neurologist, so that way they can conduct further secondary assessments and continue to rule out conditions that might be causing problems. Anxiety, mood, and symptom assessments are not something that are always within the scope of every healthcare provider. But as a physical therapist, I'm an interdisciplinary professional. So rather than go down a full route of treatment with these folks, it's up to me to simply, understand what they're going through, to take measures as needed with several of these patient-reported outcome measures, and then refer to the appropriate provider. The Beck Depression Inventory Screen, the Fear Avoidance Belief Questionnaire, or FABQ, and the Activity Balance Confidence Scale are all tools that can be used to gauge a person's, subjective opinion of how they're doing and to get their own impression as to how they feel about their injury. This can give you a lot of insight because these things do have reliability and validity associated with them and can be used to, engage in that conversation of when to refer to the next healthcare provider. And a neuropsychologist is perfect in this role because they're the ones that, handle a lot of these things associated with moods, anxiety, depression, and some other things that these patients might be feeling. Okay. When assessing cervical symptoms, the Neck Disability Index is another patient-reported outcome measure where patients can report how they're feeling with related to various functions of their neck. Range of motion, how you move in each direction. Manual muscle testing, the strength you can generate, as well as sensation, deep reflex testing, are all ways that the cervical spine can help to allude to other problems that may be coming from or causing symptoms related to a concussion. The Deep Neck Flexor Endurance Test is one that I use pretty prominently as well, which gauges the actual strength and endurance of the neck muscles and helps to identify points of stability and strength in the neck where it might be lacking, and can help to allude as to some of those risk factors associated with why a concussion might have occurred, as well as a very prominent return to play guideline that I would use as part of my recovery. Treatment for these cervical symptoms are going to be a combination of stabilization exercises, mobilization techniques, strengthening, and traction if indicated. More often than not, you're not using all of these, but rather a combination of a select few based on what the evaluation entails. And more often than not, these things can be used interchangeably or day to day based on the needs of the patient. Again, listed here more for familiarity, just so that way you can use these big, broad concepts to engage in that bigger conversation. One of the last subgroups we have here is the migraine symptom group. And really, this is more about recognition and referring, similar to the anxiety, mood, and depression group. Migraines themselves are often unilateral, so one-sided in nature, and they feel like these pounding headaches, these relentless, very forceful headaches that are often accompanied by other symptoms, such as nausea or motion sensitivity. They can be recurrent, meaning that they can come and go as they please, and are often intermittent. So they're not constant. They can come at a heightened period of time, can recede into more of a lulled period of time where they may not be bothersome at all, and can ebb and flow back and forth in that nature. And we really just want to refer to a neurologist or primary care physician at this point, because a lot of the management is going to be more medical than physical. Some of the treatments, again, involve the use of medication, stress management, exercise, diet, as well as subsequent counseling if the migraines tend to be rather severe or if there's something that's just concerning to an individual. Final group here is the cognitive symptom group. And again, these are all different tests and screening tools that a clinician can administer just to familiarize yourself with what some of these may be. The SCAT-5 we had discussed previously. The SAC test is actually a questionnaire incorporated into the SCAT-5 that subcategorizes some of the immediate recall and other memory tests that are important to cognitive function, as well as the Montreal Cognitive Assessment Tool, which has some reliable and valid measures for determining if mild cognitive impairment has occurred and if a referral to a neurologist is relevant. And this is when we incorporate some other forms of rehabilitation into our repertoire here. So a neurologist will incorporate some neurocognitive rehab that could be used in conjunction with physical medicine or rehabilitation, as well as just general exercise and education to improve people's outcomes. Overall, seeking additional care is as simple as these few steps, as well as just understanding when you might just not be feeling right. So if the symptoms don't resolve steadily in about 7 to 10 days, if the symptoms steadily increase either in severity or in intensity, duration, or if the symptoms remain after about 3 weeks, Okay, we want to make sure that we are reaching out to seek the appropriate care of a neurologist, the neuro-ophthalmologist, neuropsychiatrist, if falling into that category, or perhaps your primary care physician as needed. Key takeaways of this presentation, while dense at times, are that there are many signs and symptoms of concussions, and that no two concussions will present the same way. It's important to remember the diversity of how concussions present, because you may have certain expectations, and a person's concussion may not meet those expectations, and you don't want to risk missing something as a result of a previous bias. There are many ways to evaluate and treat concussions, though there are some gold standard measures that should be included for optimal care. That's really what a bulk of the assessment and treatment portion of our presentation is here to outline, is that these are all things that, while you may not know exactly what they are, they should be included in the standard concussion protocol. And that perhaps if something like that isn't included, you ask why. Or perhaps if it is included, you'll have a better understanding as to what is going into each one of the tests. You want to familiarize yourself with the state laws and local practice acts. These are to better educate yourself, to arm yourself with knowledge and understand how a concussion should be treated generally, and to hold folks accountable when perhaps a concussion is being treated a way differently than what you would expect, or just to ensure that the person close to you is receiving the right care. And finally, as I've been harping on the whole time, to become an advocate. So even if you don't work in the healthcare field, the idea is the information in this presentation can still help you or someone that you know reach that path to recovery. Again, there are so many different ways to access the field of healthcare these days, and so many different conditions to be concerned with. The goal is to streamline the knowledge of the signs and symptoms, the assessments and the treatments, to make decision-making for you as quick and as easy as possible and as stress-free as possible.